There is a biological process running inside your body right now that the majority of doctors do not test for, that most people have never been told to monitor, and that the latest research is identifying as the common upstream driver of nearly every major chronic disease that shortens life in the developed world. It is not a virus, it is not a genetic mutation, it is chronic systemic inflammation, and it is producing symptoms in your body right now that you almost certainly have, but almost certainly have not been told to connect to a single shared biological cause. Inflammation is not inherently dangerous. It is, in its acute form, one of the most sophisticated and essential processes in the human body. When you cut your finger, sprain your ankle, or catch a respiratory infection, your immune system launches a precisely orchestrated inflammatory response. Blood vessels dilate, immune cells flood the affected tissue, signaling proteins called cytokines, coordinate the repair, and within days the process resolves and the tissue heals. This is inflammation doing exactly what it was designed to do. It is targeted, it is temporary, and it is essential to survival. The inflammation that is silently driving disease in millions of adults is something entirely different. It is chronic, systemic, and low-grade, not the dramatic heat, swelling and redness of an acute response, but a persistent, body-wide immune activation that never fully resolves. It does not announce itself with a single dramatic symptom. It announces itself through a diffuse pattern of changes: fatigue that sleep does not fix, joint discomfort that moves and shifts, a digestive system that has become unreliable, a skin that responds to the internal inflammatory burden it is carrying. Research published in Nature Medicine has identified this state of chronic systemic inflammation as a primary driver of cardiovascular disease, type 2 diabetes, Alzheimer's disease, multiple cancers, and accelerated biological aging. And the symptoms through which it communicates are far more recognizable and far more actionable than most people have been told. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years in the AANDE, I have seen what chronic systemic inflammation looks like when it reaches its endpoint. The heart attacks and strokes in patients whose inflammatory burden had been measurably elevated for years before the event, the autoimmune crises in patients whose immune dysregulation had been signaling through fatigue, joint pain, and skin changes long before it produced the acute presentation that brought them to emergency care. The cancer diagnoses in patients whose chronic inflammatory environment had been creating the permissive tissue conditions for malignant transformation over a decade or more. My goal is to give people the biological understanding to recognize these signals earlier, when the inflammatory trajectory is still highly modifiable and when intervention changes outcomes most dramatically. If you are watching this, you are almost certainly someone who has been experiencing symptoms that have not been clearly explained, or who has received explanations that treat each symptom in isolation without ever identifying what they share. I want to make you a direct promise. I will keep creating the most rigorously researched and clearly explained content I can, grounded in the clinical experience and the scientific evidence that most standard appointments do not have time to convey. All I ask in return is that you give this channel a genuine chance and hit the subscribe button right now. If you reach the end of this video and feel you have not learned anything meaningfully new, please unsubscribe, no hard feelings at all. But if you give me your time and your attention, I will give you everything I have learned from a decade on the front line of medicine. Please hit subscribe, help this channel reach more people who need it, and let us get into it. To understand why chronic systemic inflammation produces the 7 symptoms we are about to discuss, we need to understand the inflammatory cascade well enough to see why it sometimes fails to resolve. Because the symptoms are not arbitrary, every one of them is a predictable downstream consequence of a specific part of the inflammatory system operating in a state of persistent, unresolved activation. The inflammatory cascade begins with a detection event. Specialized immune cells, primarily macrophages and dendritic cells, carry pattern recognition receptors on their surface that are designed to detect molecular signatures of 2 categories: threat pathogen-associated molecular patterns, the structural markers of bacteria, viruses, and fungi, and damage-associated molecular patterns, the molecular fragments released by injured or dying host cells. When either category is detected, the immune cell activates and begins producing pro-inflammatory cytokines, signaling proteins including interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha that broadcast the alarm signal to the surrounding tissue and recruit additional immune cells to the site. This is the beginning of the acute inflammatory response. Under normal circumstances, the inflammatory response has a built-in resolution program. Once the threat is cleared or the tissue repaired, anti-inflammatory cytokines, including interleukin-10 and transforming growth factor beta, begin to predominate. Regulatory T cells dampen the immune activation, and the tissue returns to its pre-inflammatory baseline. Specialized lipid mediators called resolvins and protectins, synthesized from omega-3 fatty acids, actively orchestrate this resolution process. Inflammation is not simply supposed to stop, it is supposed to be actively resolved, and the resolution requires specific biological inputs. Chronic systemic inflammation occurs when this resolution program fails to complete. The pro-inflammatory signals continue at a low level. The resolution inputs, including omega-3 fatty acids, adequate sleep, low visceral fat burden, and a diverse gut microbiome, are insufficient or absent, and the immune system remains in a state of persistent low-level activation. The triggers that maintain this state are precisely the features of modern life that have expanded most dramatically in the past 50 years: ultra-processed food consumption, visceral adiposity, physical inactivity, chronically disrupted sleep, chronic psychosocial stress, gut microbiome disruption, and environmental toxin exposure. Each of these maintains the inflammatory signal through a specific and well-characterized mechanism. Visceral fat, the fat stored within and around the abdominal organs, as distinct from the subcutaneous fat beneath the skin, is not metabolically inert. It is an active endocrine and immune organ that continuously produces pro-inflammatory cytokines, including TNF-alpha and IL-6, from its resident macrophage population. The volume of visceral fat is one of the strongest independent predictors of circulating inflammatory markers in population studies, and it is the primary reason that abdominal obesity is associated with cardiovascular, metabolic, and neurological disease risk independently of total body weight. The gut microbiome is the second major driver of chronic inflammation that modern medicine has been slowest to incorporate into clinical practice. The intestinal lining, a single-cell thick barrier that separates the trillions of bacteria in the gut lumen from the immune-rich tissue underneath, is continuously monitored by the gut-associated lymphoid tissue, the largest immune organ in the body. When the microbiome is diverse and the intestinal barrier is intact, this system maintains a state of controlled immune tolerance. When the barrier is disrupted by ultra-processed food, repeated antibiotic courses, chronic stress, or microbiome imbalance, bacterial lipopolysaccharide, a structural component of gram-negative bacteria, translocates across the barrier into the portal circulation, reaches the liver and systemic circulation, and activates the innate immune system through toll-like receptor 4, producing a systemic inflammatory signal that research published in Gut has identified as a primary driver of the low-grade inflammation associated with obesity, insulin resistance, and cardiovascular disease. This phenomenon, sometimes called metabolic endotoxemia, is one of the most consequential and least discussed mechanisms in modern chronic disease biology. Ultra-processed food drives inflammation through multiple simultaneous mechanisms. It provides refined carbohydrates that spike insulin and promote visceral fat accumulation. It delivers trans fats and oxidized lipids that directly activate inflammatory signaling pathways in macrophages. It is devoid of the dietary fiber that the gut microbiome requires to produce short-chain fatty acids, the primary energy source of intestinal epithelial cells, and the primary signal that maintains gut barrier integrity, and it provides a high load of advanced glycation end products, AGs, formed during high-temperature food processing, which bind to specific receptors on immune cells and directly activate the NF-κB inflammatory transcription pathway. The combination is not merely unhealthy, it is specifically and mechanistically pro-inflammatory at every level of the cascade. Here are the 7 symptoms through which chronic systemic inflammation most commonly communicates its presence, each one explained through the specific inflammatory mechanism that produces it, so that you understand not just what you are experiencing, but why your immune system is generating that signal. Inflammation-driven fatigue is one of the most prevalent and most consistently underinvestigated symptoms in clinical medicine, and it is biologically distinct from the fatigue produced by inadequate sleep or physical exertion. The mechanism is direct pro-inflammatory cytokines, particularly interleukin-1 beta and TNF-alpha, cross the blood-brain barrier and act on the hypothalamus and brainstem nuclei that regulate arousal, motivation, and energy expenditure. This produces what researchers call sickness behavior. The fatigue, cognitive slowing, social withdrawal, and reduced appetite that accompany acute infection, but in the context of chronic low-grade inflammation, it produces a persistent, lower-intensity version of the same state that does not resolve with rest. Additionally, chronic cytokine exposure suppresses mitochondrial function in skeletal muscle and brain tissue, reducing cellular energy production capacity even in the absence of any structural disease. Research published in Brain Behavior and Immunity demonstrated that circulating levels of IL-6 and CRP were independently predictive of self-reported fatigue severity in adults without active infection or diagnosed inflammatory disease, confirming that subclinical inflammatory burden is a primary and clinically significant driver of chronic fatigue in the general population. Migratory joint pain, discomfort that moves between joints over days or weeks without a consistent anatomical pattern, is a characteristic feature of systemic rather than localized inflammatory disease. In localized mechanical joint problems, pain is consistent in location, worsens with specific movements, and is explained by anatomical findings on imaging. In systemic inflammatory joint involvement, the pain is driven by cytokine-mediated synovial inflammation. The synovium, the membrane lining the joint space, is richly supplied with immune cells and highly sensitive to circulating inflammatory signals. When systemic cytokine levels are elevated, multiple joint synoviums can become simultaneously or sequentially inflamed, producing the migratory pattern that is diagnostically important. Morning stiffness, lasting more than 30 to 45 minutes, is a particularly significant feature of inflammatory rather than degenerative joint disease. It reflects the overnight accumulation of inflammatory mediators in the joint space that takes time to mobilize with movement. This symptom pattern, migratory, worst in the morning, associated with systemic fatigue, should always prompt investigation for systemic inflammatory markers and autoimmune serological testing, not simply analgesic prescription. The skin is the body's largest immune organ. Approximately 20% of its cells are immune cells, and it is continuously surveying the environment for threat signals. It is also a direct readout of systemic inflammatory status. Conditions including eczema, psoriasis, rosacea, and chronic urticaria are all driven by dysregulated immune activity in the skin, and all are significantly worsened by the same systemic inflammatory drivers: gut microbiome disruption, visceral adiposity, dietary AGE load, and elevated circulating cytokines that produce the other symptoms in this list. Research published in the Journal of Investigative Dermatology demonstrated a direct correlation between serum IL-17 levels, a pro-inflammatory cytokine, and psoriasis severity, and showed that systemic anti-inflammatory interventions produced skin improvement that paralleled reductions in circulating inflammatory markers, not merely local skin treatment effects. The clinical implication is that chronic skin inflammatory conditions should be evaluated and managed in the context of systemic inflammatory burden rather than as isolated dermatological problems. Patients who are told that their eczema or psoriasis is purely a skin condition that requires topical treatment are receiving an incomplete picture of a disease whose driving mechanisms are primarily systemic. Gut symptoms are both a cause and a consequence of systemic chronic inflammation, and their bidirectionality is one of the most important concepts in contemporary gastroenterology and immunology. As described in the science section, gut microbiome disruption and intestinal barrier dysfunction drive systemic inflammation through metabolic endotoxemia. But the relationship runs equally in the other direction. Systemic inflammatory mediators, elevated circulating cytokines, chronic cortisol from stress, and the direct effects of ultra-processed food on the intestinal epithelium disrupt gut motility, alter secretory function, sensitize the enteric nervous system, and progressively reduce microbial diversity. The result is a gut that is simultaneously a driver and a victim of the inflammatory state, bloating that is persistent rather than episodic, bowel habits that have changed in frequency or consistency without a clear dietary explanation, and a gut sensitivity to foods that were previously tolerated without difficulty are all meaningful signals that the intestinal inflammatory environment has shifted. Research published in Gastroenterology demonstrated that patients with irritable bowel syndrome, long classified as a functional disorder with no detectable pathology, showed measurably elevated mucosal immune activation and altered microbiome composition compared to controls, repositioning IBS within the spectrum of chronic, low-grade gut inflammatory disease rather than purely psychosomatic functional disorder. The immune system under chronic inflammatory load is a paradoxically compromised one. This apparent contradiction that a chronically activated immune system should be less effective at defending against acute infection resolves when the underlying biology is understood. Chronic systemic inflammation predominantly activates the innate immune system and the TH2 arm of the adaptive immune response, while simultaneously suppressing the TH1 arm, the branch responsible for antiviral and intracellular bacterial defense. The result is an immune system that is generating substantial inflammatory noise while being relatively poor at mounting the targeted, pathogen-specific responses that protect against upper respiratory infections, viral reactivation events, and slow-healing wounds. Chronic cortisol elevation, which accompanies and amplifies chronic inflammatory states, further suppresses lymphocyte proliferation and natural killer cell activity. Research published in Psychosomatic Medicine demonstrated a direct dose-response relationship between systemic inflammatory marker levels and susceptibility to experimental rhinovirus infection, confirming that the chronically inflamed immune system is measurably less capable of protecting against acute viral challenge than a well-regulated one, despite its apparent state of constant activation. The neurological consequences of chronic systemic inflammation are mediated through three primary pathways, each of which has been characterized with increasing precision over the past 2 decades. The first is direct cytokine signaling across the blood-brain barrier. IL-1 beta, Illinois-6, and TNF-alpha all have specific transport mechanisms that allow them to enter the brain and act on microglia, the brain's resident immune cells, driving their activation into a pro-inflammatory state that impairs synaptic transmission and suppresses BDNF production. The second is vagal nerve signaling. The vagus nerve continuously monitors peripheral inflammatory status and relays that information to the brainstem, allowing systemic inflammation to influence brain function without cytokines crossing the blood-brain barrier directly. The third is the disruption of tryptophan metabolism by inflammatory cytokines. Chronic inflammation diverts tryptophan away from the serotonin synthesis pathway and toward the kynurenine pathway, reducing serotonin availability and producing neuroinflammatory metabolites that impair glutamate regulation. Research published in JAMA Psychiatry identified elevated circulating inflammatory markers in approximately 1/3 of patients with treatment-resistant depression, a subgroup whose mood disorder appears driven by neuroinflammatory mechanisms rather than monoamine deficiency, and who respond poorly to standard antidepressants but may respond to anti-inflammatory interventions. The brain fog and mood disturbance of chronic inflammation are therefore not psychological consequences of feeling unwell. They are direct neurobiological consequences of systemic inflammatory mediators acting on neural tissue. Chronic inflammation drives weight gain and fat loss resistance through a set of mechanisms that are distinct from simple caloric imbalance, which is why standard dietary advice frequently fails for individuals with significant inflammatory burden. Pro-inflammatory cytokines, particularly TNF-alpha, directly impair insulin receptor signaling at the cellular level, producing insulin resistance that locks fat cells into storage mode, prevents lipolysis even in the context of caloric restriction. Simultaneously, chronic inflammation disrupts the hormonal regulation of appetite. Leptin, the satiety hormone produced by adipocytes to signal energy sufficiency to the hypothalamus, becomes progressively less effective in a high inflammatory environment, as cytokines induce leptin resistance in the hypothalamic neurons that should be receiving its signal. The result is that the inflamed body is simultaneously storing fat more aggressively and failing to suppress appetite appropriately, creating a biological environment in which weight gain is the path of least resistance, and fat loss requires overcoming not merely caloric deficit, but a hormonal and inflammatory state that is working directly against it. Research published in Obesity demonstrated that elevated CRP, the primary clinical marker of systemic inflammation, was an independent predictor of weight loss failure in dietary intervention. Programs with high CRP individuals achieving significantly smaller weight reductions per unit of caloric deficit than low CRP controls. Addressing the inflammatory driver before attempting aggressive caloric restriction is not optional for this group. It is a prerequisite for the intervention to work. The unifying thread across all 7 symptoms is that they are each expressions of a single overarching biological state, the immune system in a mode of chronic, unresolved activation, distributed across different organ systems according to each individual's genetic susceptibilities, prior exposures, and specific inflammatory triggers. Recognizing that these symptoms share a common upstream driver is what transforms the clinical approach from individual symptom management to root cause resolution. If this is connecting symptoms you have been experiencing to a biology you were not previously given, and if that connection is useful to you, please take 5 seconds to hit the subscribe button. It genuinely helps this content reach more people who need it. Now let us get into what the evidence says actually reduces chronic systemic inflammation at its source. Words 2800 4200 vertical bar 25-30% of script vertical bar 5-9 minutes. I want to frame this section carefully. If you have symptoms that suggest an active autoimmune condition, severe joint inflammation, significant skin involvement, systemic symptoms accompanied by fever or unintended weight loss, a clinical assessment and appropriate investigation are the necessary first step, and what follows complements rather than replaces that pathway. For the majority of people experiencing the symptoms described in this video in their milder to moderate form, the interventions I am about to discuss address the inflammatory mechanisms at their biological source, not by suppressing the immune response as pharmaceutical anti-inflammatory agents do, but by removing the inputs that are maintaining the inflammatory signal and restoring the inputs that the resolution program requires. The single most impactful dietary intervention for reducing chronic systemic inflammation is the sustained reduction of ultra-processed food consumption, because ultra-processed food simultaneously drives inflammation through every mechanism described in the science section. It promotes visceral fat accumulation, disrupts the gut microbiome, delivers ages and oxidized lipids that directly activate macrophage inflammatory pathways, and deprives the body of the fiber and micronutrients that the resolution program requires. Research published in the BMJ demonstrated that each 10% increase in the proportion of ultra-processed food in the diet was associated with a significant increase in circulating CRP Illinois NIS6, an overall inflammatory score independent of total caloric intake, macronutrient composition, and body weight. The inflammation is not simply a consequence of the obesity that ultra-processed food promotes. It is a direct pharmacological effect of the specific compounds these foods contain. The dietary pattern with the strongest anti-inflammatory evidence base is the Mediterranean dietary pattern, characterized by high intake of olive oil, vegetables, legumes, nuts, oily fish, and moderate red wine intake with low ultra-processed food consumption. Research published in Circulation demonstrated that adherence to a Mediterranean dietary pattern significantly reduced circulating levels of CRP, Illinois 6, and fibrinogen, all primary markers of systemic inflammation, within 12 weeks, with effects that were independent of caloric intake and body weight change. The mechanistic basis is the combination of high omega-3 and polyphenol content, both of which directly promote the resolution phase of the inflammatory cascade, rather than simply suppressing initiation and high dietary fiber diversity, which restores gut microbiome composition and reduces metabolic endotoxemia. Omega-3 fatty acids, particularly EPA and DHA, from oily fish or algae-based sources, are not simply anti-inflammatory in the general sense of reducing inflammatory markers. They are the direct precursors of the specialized pro-resolving mediators, resolvins, protectins, and merisins that actively orchestrate the resolution phase of the inflammatory cascade. Without adequate omega-3 availability, the resolution program cannot proceed fully, and the inflammatory state persists by default rather than by active maintenance. This is a mechanistically specific and clinically important distinction. Omega-3s do not suppress inflammation in the way that ibuprofen or corticosteroids do. They complete the resolution process that chronic inflammation has left unfinished. Research published in the New England Journal of Medicine, the VITAL trial, demonstrated that omega-3 supplementation at 1 gram of EPA plus DHA per day produced a significant reduction in major cardiovascular events in a large population trial, with the effect size substantially larger in individuals with lower baseline fish intake. A subsequent analysis demonstrated that the cardiovascular protection was mediated at least in part through reductions in circulating inflammatory markers and improvements in resolution mediator profiles. 2 to 3 servings of oily fish per week, or algae-based omega-3 supplementation at equivalent doses for those who do not consume fish, represents the most evidence-supported dietary intervention for supporting the inflammation resolution program. Restoring gut microbiome diversity and intestinal barrier integrity directly addresses one of the primary drivers of chronic systemic inflammation, metabolic endotoxemia, through a mechanism that no pharmaceutical anti-inflammatory agent targets. The dietary inputs with the most consistent evidence for microbiome restoration are diverse plant-based dietary fiber, with diversity of fiber sources being at least as important as total fiber, quantity, and fermented foods, which provide direct microbial inputs that increase gut bacterial diversity and have been shown to reduce circulating inflammatory markers. Research published in Cell, one of the landmark microbiome intervention studies of the past decade, demonstrated that a high-fiber, high-fermented food dietary pattern over 10 weeks significantly increased microbiome diversity and produced measurable reductions in 19 of the 23 inflammatory proteins measured, including proteins previously associated with type 2 diabetes, cardiovascular disease, and neurological inflammatory conditions. The magnitude of the inflammatory reduction was directly proportional to the degree of microbiome diversity improvement, confirming the mechanistic relationship between gut ecosystem health and systemic inflammatory status. Physical exercise produces both acute and chronic anti-inflammatory effects through mechanisms that are distinct from its cardiovascular and metabolic benefits. During exercise, contracting skeletal muscle produces and releases a class of signaling molecules called myokines, including IL-6 in a specific exercise-induced isoform. Unlike the chronically elevated inflammatory IL-6 of metabolic disease, actually promotes anti-inflammatory IL-10 production and reduces TNF-alpha synthesis. This exercise-induced IL-6 pulse is part of the mechanism through which regular physical activity trains the immune system toward a less reactive baseline inflammatory state. Research published in Brain Behavior and Immunity demonstrated that adults who engaged in regular moderate to vigorous physical activity had significantly lower circulating levels of CRP, Illinois, 6, and TNF-alpha than sedentary controls, with the anti-inflammatory effect emerging within 6 to 8 weeks of consistent exercise and proportional to training frequency and intensity. Both aerobic and resistance training contribute to this effect, and the combination produces greater inflammatory reduction than either modality alone,